through the importer, the iodide enters, and then afterwards it's then coupled to the tyrosine residues that are sticking out on the thyroglobulin molecules through a process of organification that is facilitated by the thyroid peroxidase enzyme. So organification as well as the coupling of the monoiodo. So the iodine is coupled to tyrosine residue, monoiodo or diiodo. And that coupling reaction then leads to the formation of T4 and T3. Then the preformed hormone is stored in the thyroglobulin when anytime TSH signals secretion to hydrolyze thyroglobulin, releasing the free MIT, monoiodo, diiodo, and the T3, T4. And then subsequently, in the peripheral, in the tissues, T4 is converted to T3. And T3 is considered to be the active hormone, but T4 is still the predominant hormone in your blood circulation. Okay, and so just then, if you're hypothyroid, there are several thyroid hormone preparations, but the drug of choice, like I said, is levothyroxine. And then just to let you know that this is the replacement dose. So how this computes is that if in a approximately 50 kilogram person, it computes to around 80 micrograms. So kung 60 kilograms, that's around 90 something. And that's why the typical default dose for replacement is around 100 micrograms per day. So this is because of this dose calculation. And then, and your target is just to normalize the TSH. Now, if on the other hand, you're treating nodules, you want to suppress growth, or after thyroid cancer, you want to prevent regrowth of the thyroid cancer cells, you give a higher dose, as much as 3 microgram per kilogram. And the only exceptions to this, because you can start right off with the full dose, is for elderly, those with coronary artery disease or at risk of arrhythmias, of course, want to give it at probably a fourth or even half the dose, and then titrate accordingly over several days. So these are some of the indications. So any of the causes of hypothyroidism, whether congenital, autoimmune, post-procedural, post-RAI, can be given thyroid hormones. And like I said, the drug of choice is synthetic levothyroxine, or shorthand is LT4, because of its stability, the uniform content, relatively long half-life, and within the body, it is converted to, it is in the peripheral tissue converted to T3. Now, desiccated thyroid used to be available internationally. It's not anymore. So historical highlights na lang yan. Also because of its antigenicity and variable hormone content, it's not given anymore. T3 is an available preparation, and you would think that because T3 is the active hormone that you would want to give it, but it's not recommended because it was leading to a lot of toxicity, especially cardiotoxicity, because again, you want T4 to be the predominant hormone in your blood circulation, and for it to be converted to T3 within the cells themselves. And so therefore, if you expose the tissues that have thyroid hormone receptors, it might potentially lead to some toxicity. So this is no longer used for replacement. Ginagamit lang siya kung minsan if we need to prepare them, for example, for a procedure, and you want to give a drug that you can discontinue quite quickly, kasi shorter yung half-life niya, then we give liothyronine. And finally, there used to be a combination of T4 and T3 that mimics the natural combination of what we're supposed to have in our blood circulation. But again, it had the same advantages as liothyronine of toxicity, and that's why it's no longer used. So it's really just T4 that is used in practice. Now, the antithyroid drugs, there's a whole set of them. And what do you need to know about the antithyroid drugs? Number one, you need to know that the drug of choice for treatment of any of the causes of hyperthyroidism is methimazole, not PTU. The only exceptions to what I said would be pregnancy, especially the first time, where PTU is preferred. And also in thyroid storm, because of the additional effect of PTU of inhibiting peripheral conversion of T4 to T3, then those are probably the two exceptions. And of course, if you have allergies to methimazole. The other highlight that you have to remember is that carbimazole is the prodrug of methimazole. Kasi ganun sa boards, nagtatanong ng mga trivia. Well, that's also important, there. So carbimazole is the prodrug of methimazole and is converted to methimazole in the body. We also can use high-dose iodides, but in gram amounts, in order to inhibit the release of thyroid hormones. We give radioactive iodine for thyroid hormone ablation, and of course the adjunctive drugs like the beta blockers, especially the non-cardioselective, and glucocorticoids. Okay, so again, the action of the thionamides is in inhibiting the action of the thyroid peroxidase enzyme, and the TPO-mediated, thyroid peroxidase mediated steps of iodination and coupling. So these drugs are preferentially iodinated and depriving thyroglobulin of iodide and shutting down the synthesis of thyroid hormones. This is the reason why the thionamides are the drug of choice for hyperthyroidism, especially methimazole in the outpatient. Now, carbimazole as a prodrug has a 10:6 conversion, meaning if you want to approximate the 5 or 6 milligrams of methimazole, you have to give 10 milligrams of carbimazole. And PTU is 50 milligrams. That's equivalent to 5 milligrams of methimazole in terms of their effect, supposed effects. Now, in terms of adverse drug reaction, we'll talk about that briefly. And again, methimazole is the preferred drug because it has a better compliance, being given once or twice a day, versus PTU, which is relatively short acting and therefore needs to be given 2 to 3 times a day. Okay, so please take note of this in terms of the dose, so that in the OPD, once you start seeing patients with, let's say, Graves' disease, you would know how to then give your doses. So the initial dose of methimazole is around 10 to 30 milligrams, and the methimazole preparations kasi is here is 5, 20, and even 30 milligrams. Then the dose can be titrated down to a maintenance level of around 5 to 10 milligrams, methimazole being the drug of choice. The American Thyroid Association has also made this recommendation. Kailan mas mataas, kailan mas mababa. So take a look at your free T4 level. If the free T4 level is 2 to 3 times the upper limit of normal, then you give a relatively high dose. So 2 of the 20 milligrams or 1 of the 30 milligram, then that's the dose. If on the other hand, the patient is coming to you with very mild hyperthyroidism, then you can give the lower limit, which is around 10 milligrams per day. Now, just take note also that methimazole is the same as thiamazole. Ano lang yan, parang paracetamol and acetaminophen. Thiamazole is chemically the same as methimazole. Okay, the most life-threatening adverse drug reaction is agranulocytosis. So please take note, it's uncommon, but it's life-threatening. It typically develops early, within the first 2 to 3 months. And of the 2 main drugs, PTU is actually the more likely to cause agranulocytosis. Unfortunately, it's an idiosyncratic reaction, and therefore it's hard to predict. But even if that were so, it tends to occur actually at higher doses. So that's what we've seen in the reports. The other important adverse drug reaction is hepatotoxicity. And ito parati rin tong tinatanong sa endorsements, what kind of toxicity do you expect? while PTU is the one that is more notorious, causing fulminant hepatic necrosis, hepatocellular injury that may be fatal and abroad necessitates liver transplantation. Methimazole can also cause actually cholestatic jaundice. So yun yung kaibahan nila. If it's hepatocellular, that's probably PTU, cytotoxic. And if it's cholestatic, that's probably methimazole. And that's the reason why PTU has a black box warning. And also one of the reasons why methimazole is preferred, because of this risk for hepatic necrosis, which again is idiosyncratic, but tends to occur at higher doses. Okay, and just to summarize then, the action of the different drugs, I didn't really talk about the anions like perchlorate, etc., but they're not used anymore in practice actually. But if you want to know, they inhibit actually the symporter, disallowing the entry of the iodine. And radioactive iodine, if you get it, if you give it, it causes selective thyroid destruction. High levels of iodides, they reduce the T3 and T4 levels peripherally by inhibiting the thyroglobulin proteolysis, and this is what it inhibits. And the thionamides block the two steps that are brought about by thyroid peroxidase enzyme. That's the organification and the coupling reactions. It's thionamides as well as actually high dose iodides that inhibit those synthetic steps. And for peripheral conversion, it's PTU, propranolol, and glucocorticoids. So just again to reprise that, for iodide transport and entry, it's the inorganic anions, although they're not anymore used. But this is the principle why you shouldn't eat a lot of thiocyanate-containing foods, for example, like cassava, because they inhibit iodide transport. For the oxidation, organification, and coupling steps, these are the thionamide drugs and high-dose iodides. For the release, the proteolysis, again, it's the high-dose iodides, as well as actually lithium. That's a drug that's known to inhibit the release of thyroid hormones, and inhibiting T4 to T3 conversion are the following. Okay, finally, for radioactive iodine, you will encounter this when you rotate. They're given for definitive therapy of people with hyperthyroidism from Graves, for example, or from functioning adenomas. They're orally given as solution or capsulized. These are the two radioisotopes, iodine-131 and iodine-123. Their advantage is that they're easy to administer. They're done on an outpatient basis. They're very they're not that cheap, but they're lower expense compared to, let's say, surgery. And it's done on an outpatient basis, but the major disadvantage really is lifelong hypothyroidism. 95% of everyone who received radioactive iodine for treatment of hyperthyroidism do become hypothyroid within 5 years. And the main contraindication, because this is a radioactive substance, is of course pregnancy. And that's the reason why women who will undergo RAI are advised some form of contraception or abstinence. So the rationale for its action, or the mechanism of action, is that the beta ray emission destroys the thyroid parenchyma. Some of the common adverse reactions, acute ones, are sore throat and pain in your salivary glands, cyanidinitis, and some inflammation, and permanent hypothyroidism in 95% of all individuals. But the onset of action is typically delayed, with the optimal effect seen within 3 to 6 months. Okay. Questions before we take some polling to test whether, again, we'll do some polling first, and then we'll take questions. So what is the drug of choice for the treatment of most of the causes of hyperthyroidism? Thimasol, carbimazole, sorry, jump. PTU or saturated solution of potassium iodide. Okay, very good. Antok na si Franz na umulit. Okay, next, what is the most life-threatening adverse drug reaction of the use of the thionamide drugs? Is it drug-induced lupus, seizures, hypoglycemia, or granulocytosis? Okay, sobrang nakakabobo naman yung question ko, no? Sorry. Next, which of the following drugs inhibit the release of preformed and stored thyroid hormones? So inhibition of the release of preformed hormones. Propranolol, hydrocortisone, lithium, or PTU? Okay, so it's actually lithium. Okay. Which of these has a black box warning with regards to liver toxicity? Methimazole, carbimazole, PTU, or iodides? So, okay. Thank you, Franz. It's actually PTU. Nagkamali lang ng konti dito sa sharing, but the last one is saturated solution of potassium iodide. There are also unique adverse drug reactions to SSKI, for most of which is that you can develop angioedema and allergies. So that when you give iodides, please also be careful because the risk of allergy is high. Okay. The following is the main mechanism of action of your antithyroid thiourea drugs. Is it interference with the secretion of preformed hormones, absorption, inhibition of the transport of iodine, or is it interference with the EPO-mediated coupling of iodothyronase? Okay. So, kulang pa. It's actually the inhibition. It's not the transport, not the symporter. So sa symporter ang nag-i-inhibit yung mga, like I said, the inorganic anions. No? So it's actually inhibition of the thyroid peroxidase mediated steps of coupling of iodine to the tyrosine residues and the coupling of the mono and the diiodine. So what is the preferred thyroid preparation for maintenance therapy of any of the causes of hypothyroidism? Liothyronine, levothyroxine, desiccated thyroid, or Leotrix? Okay. 100% na yan, Franz. So thank you, everyone. Okay, last na ba to? Your 70-year-old patient underwent thyroidectomy. The biopsy is benign, but the post-op TSH 1 month after surgery is already 44. Which of the following is true about the correct initial dose? You start full dose, you start at half dose, you start right away with a suppressive dose because you don't want it to regrow, and finally, there's no need to start. Okay, so the first action point is, what is the diagnosis? It's post-op hypothyroidism, post-surgical hypothyroidism. Your TSH is high. And so do you want to treat it? Yes, of course you want to treat it. And it says, well, the treatment is 1.6 to 1.7 microgram per kilo. And because it's not thyroid cancer, it's actually just a benign biopsy result, then you just give a replacement dose. Kahit hindi suppression dose, pwede. Especially in a 70-year-old. So kung suppression dose yan, mga 100 microgram lang siguro, although the weight wasn't given. So you don't want to give the full dose right away. So the correct answer is B. So you want to give a replacement rather than a suppression dose, but you don't want to give the full dose right away. Okay, so maybe we'll take a 5-minute break before I go to the next part. So you can also just get a drink and get something. Sige, I'll just time it. So we'll come back It's 2:40 by my watch. We'll come back at 2:45. 5 minutes lang muna. Corticosteroid agonist and antagonist. So the concept map is that, again, if you are lacking glucocorticoids for whatever reason, again, pwedeng pituitary problem, pwedeng meron kang adrenal insufficiency from autoimmune problems, then again, glucocorticoid replacement, where the drug of choice is typically prednisone or actually hydrocortisone for long-term replacement. And if you need to replace even the mineralocorticoids, the drug of choice is fludrocortisone. Now, if on the other hand, you have excess endogenous steroids, such as in Cushing's syndrome or Cushing's disease, if it's in the pituitary, so hindi ka maoperahan or you want to be prepared for surgery, then you may give synthesis inhibitors, such as, let's say, ketoconazole. So we'll tackle that. And on the other hand, yung isang problem naman, if you have excess of the mineralocorticoid aldosterone, such as in primary or secondary hyperaldosteronism, then you can also give antagonists such as spironolactone. So we'll take in a few questions before I begin. So let's say first, among the steroids, what is the drug of choice for emergency treatment after of anaphylaxis concomitant with epinephrine? Okay, so the correct answer is hydrocortisone, which the greater majority of you got. You would like the mineralocorticoid effect of hydrocortisone because typically in anaphylaxis, they will be going into hypotension as well because they're vasodilated. All the steroids potentiate the effect of epinephrine, but you would prefer the rapid-acting drugs with mineralocorticoid effect. Now, kung wala talagang hydrocortisone, let's say nasa labas, whatever, prednisone may also be given. It is an intermediate in terms of the duration of action. It's intermediate. Pero kung wala talaga, tas nabigay mo na naman yung epinephrine, then prednisone probably is the alternative. Next. Generally, glucocorticoids with high inflammatory potential are also seen or characterized as having the following characteristics. Mataas din yung mineralocorticoid potency niya, no? Short half-life, lower glucocorticoid effect, minimizing hyperglycemia, or a long biologic half-life. Yan, yung mga okay. So the answer is actually D. They have a longer biologic half-life. And I'll show you that later in the table. So typically, sa glucocorticoids, the higher is the anti-inflammatory potential, the higher is the glucose elevating effect. Tapos baliktad sila. Mas mataas yung anti-inflammatory effect, mas mababa yung mineralocorticoid effect. Okay, so the following drugs, glucocorticoids, have the highest mineralocorticoid potential. A, dexa, B, betametasone, C, prednisone, and D, hydrocortisone. Okay, so the correct answer is hydrocortisone. Okay, so for this part of the lecture on glucocorticoids, the typical indication for glucocorticoids is actually non-endocrine, no? Pero nakasulat lang siya dito because these are, of course, hormones. And but the typical use, of course, of the glucocorticoids is for many different kinds of autoimmune and inflammatory conditions, no? And this table is important in that you need to take note of what are short-acting, and the short-acting are the pharmacologic equivalents of cortisol itself. So that's hydrocort and cortisone. Now, the commonly used drugs like the prednisone, methylpred, prednisolone, they're intermediate acting, no? And typically, lahat ng fluorinated drugs except for triamcinolone, they're long-acting. So fluorinated kasi yung triam, beta, and dexa. Except for triamcinolone, they're all, the two, beta and dexa, are long-acting. Now here, what's important also to take note in this table is, like what I said, the highest anti-inflammatory potential or potency is seen with the fluorinated drugs, especially the long-acting fluorinated drugs. So yun yung tanong. The higher is the anti-inflammatory effect, the higher is the glucose elevating effect. And they're typically seen among the long-acting glucocorticoids like beta and dexa. So maraming dinedexa, for example, in neurosurgery, for increasing, let's say, tumors, no, intracranial tumors, etc. So, yeah, mataas ang anti-inflammatory potential. Or let's say in COVID, no, we're giving DEXA, for example, at 0.6 milligrams, I believe 6 milligrams per day, medyo mataas. So, mataas ang anti-inflammatory potential niya. Kaya DEXA yung binibigay. Tapos baliktad, the salt-retaining or the mineralocorticoid effect, mababa. So if they have strong anti-inflammatory potential, they have relatively less salt-retaining potential. And the standard for mineralocorticoid potential is the pharmacologic equivalent of cortisol, which is hydrocortisone. So 1 siya in terms of salt-retaining and anti-inflammatory potential. Now, going up, no, from the short-acting to the long-acting, pataas din yung anti-inflammatory potential nila. So 1 sa hydrocort, 4 to 5 sa prednisone, and then around 30 for the long-acting. As baliktad yung mineralocorticoid potential, 1, tapos less than 1, tapos nearly 0 for the fluorinated derivatives. Finally, we go to the mineralocorticoids. No? Fludrocortisone, for example, is actually also a glucocorticoid, but it's a very strong mineralocorticoid or salt-retaining potential, and it's thus used in the treatment of disease conditions where you require the mineralocorticoids, like in congenital adrenal hyperplasia, for example, or in bilateral injury to the adrenals, like in adrenal TB or adrenal cancer, for example. Now, what you need to remember is, for example, in the dosing for acute in-hospital therapy, the typical dose is calibrated typically to prednisone, no? Which is one of the most, or if not the most commonly used steroid. And the typical dose for acute treatment, let's say an acute asthma, or let's say you have rheumatoid arthritis or lupus, is around 1 milligram per kilogram per day. Sa children, I think even double, 1 to 2. So kung ano siya, 50 kilogram person, that's about 50 milligrams in divided doses. The higher dose in the morning and the smaller dose in the evening. If on the other hand, nagmamadali ka and you want a drug which has more rapid action, especially because it can be given parenterally, then you want to give hydrocortisone. So, dodoblihin mo lang. So, 50 milligrams per day times 4, because that's the equivalent. So, that's around 200 milligram per day of hydrocortisone. Kaya yung dose din ng hydrocortisone, typically 200 to 300 milligrams siya. Only because the anti-inflammatory potential of hydrocort is less than prednisone. So yun yung rationale. And that's why, let's say, for conditions like critical illness-related adrenal insufficiency or corticosteroid insufficiency, the so-called CIRSE, that happens in sepsis. So nagka-sepsis ka, tapos nag-hypotension, unresponsive to your fluid challenges, and you think that there might be already adrenal insufficiency. The typical dose is 200 milligrams per day. So that's 50 milligrams of hydrocortisone divided into 4 or Q6, 50 Q6. So para alam nyo lang. So kunyari, meron kayong na-encounter na asthma, acute asthma, and then you'd like to give prednisone. The typical dose is 1 milligram per kilogram. Kung hindi masyadong severe, pwedeng half, 0.5. But the typical dose is for acute, especially life-threatening problems, is 1 milligram per kilogram. So moving on, That's for the systemic steroids. For topical steroids, especially for intranasal, as well as respiratory corticosteroids. Ang importante nyo lang matandaan dito, and this is from your previous modules, is which one you want for intranasal corticosteroids. You want something that has a high lipophilicity so that it is actually retained, no? And with an enhanced glucocorticoid receptor binding. So the ones that are higher in the alphabet, mometasone and fluticasone, are the ones with a better lipophilicity, and the Bs, budesonide and beclometasone, mas mababa yung lipophilicity. Thankfully, in the Philippines, we don't actually have this drug, flunisolide, but if you just want to know, it has the least lipophilicity. And this is shown by this table that flunisolide has a high systemic bioavailability. Ibig sabihin, hindi siya nare-retain. It just goes into the circulation. Kaya mataas yung systemic bioavailability niya after intranasal dose. And that's the reason why for nasal steroids, it's fluticasone, mometasone, or even triamcinolone that are typically used in practice. Okay, now just to let you know though that despite the low lipophilicity, flunisolide more than makes up for it by being a more potent topical steroid actually compared to fluticasone and mometasone, as well as beclo and budesonide. So ang tatandaan nyo lang naman dyan is yung lipophilicity. It's the higher alphabet, mometasone and fluticasone. Halos equivalent naman sila actually. So mometasone and fluticasone. Then the Bs, and then the least is FLU or flunisolide. Okay, now for this part of the lecture, these do not really have a lot of clinical applications anymore. A lot of them are not even available in the Philippines and internationally. But we just need to then discuss them because tinatanong pa rin kasi sila. So just to then walk you through the pathway of steroid biosynthesis. This is the pathway for the mineralocorticoids, for cortisol, glucocorticoid, and for the androgens. And the first step, of course, a common precursor, cholesterol, converted to pregnenolone. And along this path, you have many inhibitors of the enzymes, no, that convert one molecule to the next. No? So some of these drugs are specific, some are non-specific. And anong gamit nitong mga inhibitors na to? They're mainly actually adjuncts for the treatment of Cushing's disease. Kunyari, inoperable siya or preparing for surgery. Gusto mong ibaba yung cortisol levels because the sugars are going up, the patient is hypertensive, difficult to control. You may want to give certain drugs that will lower down your cortisol level. And which are these drugs? The one right off that we used to use is actually an azole, antifungal, and that's ketoconazole, because ketoconazole is very non-specific and inhibits many of the CYP enzymes. And so it inhibits the first step and many of the subsequent steps. And then just to let you know, therefore, para ito, pwede nyo na lang itong basahin sa handout, there are actually 5 different glucocorticoid inhibitors and antagonists that are listed. Aminoglutamide as well as etomidate inhibit step 1 here. So they're relatively specific, yung conversion of cholesterol to pregnenolone. So that's etomidate and aminoglutamide. So madali tandaan kasi A sila eh. So A in the alphabet. So unang step siya. Okay? Now, susunod yung mga non-specific. Ketoconazole is not specific. Even mitotane is not specific. But among them, it's actually ketoconazole and metirapone, which is a lot used as adjuncts for Cushing's disease. Mitotane is used in the chemotherapy of adrenocortical cancer and has been shown to reduce the size of the cancer. So just to show you the action of mitotane and metirapone, so very non-specific along the pathway. No? Sorry, mitotane especially and ketoconazole. Metirapone is relatively more specific. Sa 11-beta hydroxylation siya nag-work. And it can be used as an adjunct in Cushing's disease. Finally, you just need to know about this drug, mifepristone, or it has been, if you in drug development, it's been labeled to be RU486. It's a glucocorticoid receptor antagonist when given at high doses, but it's also an anti-progestin. It's actually an anti-abortive fashion, and that's why it's also not a lot in use. No? So many of these drugs, kaya skip ko na siya, are available only for compassionate use even internationally. Kahit na yung ketoconazole, hindi na siya available in the Philippines. It's been pulled out because of the hepatotoxicity from ketoconazole. But if you need it, let's say for adjunctive treatment of Cushing's disease, it may still be requested from the manufacturer. So hindi pa naman siya completely full. So I'll jump to so I talked about the glucocorticoid receptor antagonist and the glucocorticoid synthesis inhibitors. Walang masyadong gamit kasi a lot of them for uncommon diseases like adrenocortical cancer or Cushing's. But the mineralocorticoid antagonists, they're a lot used. No, they are antagonists of aldosterone, competed aldosterone for its receptor. They're a lot used for hypertension of any cause, but especially hypertension due to primary aldosteronism, due to a tumor, a benign tumor in your adrenal gland, and also for congestive heart failure. Now, please take note that spironolactone as a mineralocorticoid antagonist, again, following an endocrine principle that given its structure activity relationship, it can actually also occupy the androgen receptor, no? And that's why it can act as an androgen antagonist, and therefore it can be given for the treatment of hirsutism among women. And that's also the reason why there is an adverse drug reaction of gynecomastia in men who are taking spironolactone, because it sits not only on the aldosterone receptor but also on the androgen receptor. It's also a potassium-sparing diuretic, but it's a very weak diuretic, and the optimal effects are seen after several months. No? And being a potassium-sparing diuretic, it may cause hyperkalemia by antagonizing the effect of aldosterone of potassium secretion. Now, spironolactone has these adverse drug reactions, especially the disturbing gynecomastia in men and the problems with hyperkalemia, and thus a more selective, a drug that is more selective for the mineralocorticoid receptor has been manufactured. It's called eplerenone. So please take note, because it's not that new, but it's a relatively new drug. Spironolactone is the one that has no selectivity, but it is eplerenone that is more selective for the mineralocorticoid receptor. And thus the hyperkalemia is less, no, compared to spironolactone. Okay, now I've talked about the antagonists, no, and now I'll talk about the mineralocorticoid agonists. So there are certain individuals hindi sapat or hindi kaya ng glucocorticoids with mineralocorticoid effects to bring up the blood pressure and to prevent the problems which are due to the lack of the mineralocorticoid. So if you need replacement, let's say in a bilateral adrenal problem, such as in Addison's disease or congenital adrenal hyperplasia, or you've had a bilateral adrenalectomy because of a tumor, then you need to replace not only the glucocorticoids but the mineralocorticoids. And the agonist for that is called fludrocortisone. Okay. So two drugs to remember: eplerenone, it's an antagonist for the aldosterone receptor, and it's the one that's selective. It doesn't sit on the receptor for testosterone or for androgens. And fludrocortisone, which is the mineralocorticoid agonist. Okay, so we're done with 3. We move on to the drugs for osteoporosis. So maybe again, it's 3:10. You're okay to just continue on? You want a brief break?
Okay lang to continue, ma'am.
Okay. If there are questions, please just put them in the chat box so we can answer them. Just alert me, Franz, if there are questions. Okay, so we go to the drugs for osteoporosis. And again, the way to conceptualize the drugs for osteoporosis is that there are two main kinds, the hormonal approaches and the non-hormonal approaches. For the hormonal approaches, there are several, and for the non-hormonal, although these are actually the drugs of choice, especially the bisphosphonates. Now, what do you have to know about drugs for osteoporosis? First is, of course, you want to prevent osteoporosis. And you want to prevent osteoporosis, especially in our country where we are not natural milk drinkers. And so these are the new RENI, or the requirements for calcium as well as vitamin D. So just take note that for the average male and female adult, the requirement is around 750 milligrams. For older women, especially the menopausal, it's around 800. But like I will tell you later, the Osteoporosis Society actually recommends a much higher dose for the postmenopausal. Ang recommendation nila ng OSPI is actually 1,000 milligrams of calcium, rather than just 800 milligrams such as shown here. The other important point you have to remember is madali lang magreseta ng calcium, but what is the preferred calcium supplement? And here you can see that while calcium citrate presents an advantage that you can take it anytime as compared to calcium carbonate, the advantage of the calcium carbonate is the much higher elemental calcium content compared to the rest of the preparation. And that's why in the commonly available over-the-counter calcium preparations, it's actually calcium carbonate that is often prescribed, or that's often bought. Now for the vitamin D preparations, we actually only have now 2 in the market. There used to be a lot of different vitamin D analogs that are available. They're typically given together with calcium, but these are also the drugs that are used for treating hypovitaminosis for whatever cause, because vitamin D has been said to have many important functions, including immune modulation. So the 2 commonly available drugs are actually cholecalciferol and calcitriol. Cholecalciferol is the one that's typically added to calcium or even to the multivitamin preparations. And as you know, inside the body, it will then be converted to by 2 hydroxylation reactions in the liver and kidney into active vitamin D3. Calcitriol, on the other hand, is an analog. And the reason why it's not the preferred drug is, number one, it's relatively, of course, it's relatively more, the reason is because it's relatively more expensive. So pwede namang siya, kasi siya yung active vitamin D3. But compared to cholecalciferol, na frequently added na lang siya sa calcium as a bonus, and so it's relatively cheap. Calcitriol is probably 4 to 5 times more expensive. And that's why the Osteoporosis Society said that while they recommend around 1,000 milligram of calcium, they recommend also around 400 to 800 IU of vitamin D3 per day. And they don't routinely recommend to give the vitamin D analog, which is calcitriol. Now, moving on to the treatment of osteoporosis, perhaps this is the most important table. I'm really sorry I haven't been able to update this from the time that I was lecturing this in LU4. But here, what's important is for you to just realize what is the anti-catabolic or the anti-resorptive, and what is the anabolic or bone-forming. And at the moment, the one that is recognized to be anabolic is really the analog of the 1 to 34 fragment of the parathyroid hormone called teriparatide. So teriparatide is a PTH analog. While strontium, as I will tell you later, has a dual action of being anti and being also anabolic, strontium is relatively weak drug in terms of inducing both, and that's why it's not typically the preferred drug. And the preferred drug is typically bisphosphonates, and for some, denosumab or teriparatide. Pero talaga mostly bisphosphonates. No? So I also put in denosumab. It's a relatively new drug for the treatment of osteoporosis. Okay, so bisphosphonates are typically the drug of choice for most of the causes of osteoporosis. There are two main kinds of bisphosphonates, the non-nitrogen containing, hindi na rin sila masyadong ginagamit. No? These are, the difference is that their mechanism of action is that they bind to the bone mineral and they're internalized. And once they are then internalized in the osteoclast, they're converted to ATP analogs that induce osteoclast apoptosis. And on the other hand, the nitrogen-containing bisphosphonates, which are the ones that we typically use in practice, alendronate, ibandronate, zoledronic acid, risedronic acid, and even pabildronate, they inhibit the rate-limiting step in the mevalonate pathway that is critical for osteoclast survival. So if this is the osteoclast makes this ruffled border where, in fact, they produce these acidic vesicles that then resorb the bone. With the bisphosphonate treatment, you inhibit this first step, this enzyme, and so you prevent the formation of these acidic vesicles. These are then retained, and therefore this leads to osteoclast apoptosis. And for a long period of time, bisphosphonates were the only drugs that were available as effective treatments for osteoporosis, but it does have some adverse effects. No? And that's the reason why they look for more molecules. The common adverse drug reaction is that of heartburn and esophageal irritation or even esophagitis. And so the common instruction for when they take these drugs is to take it first thing in the morning and to stay upright for an hour or two, or they don't go back to sleep na after they take the drug to prevent the esophagitis. Now, the life-threatening and disabling adverse drug reaction, which is the reason why we are careful with using bisphosphonates, is the occurrence of serious osteonecrosis of the jaw. So although it's uncommon, they have seen it in people who have carious teeth, and that's why we need to routinely ask about these problems before we start bisphosphonates. And therefore, the US FDA has issued an alert on the use of bisphosphonates, especially after they have actually taken the bisphosphonates for quite some time. It doesn't happen during the first few years. Typically, if they're taking the bisphosphonates for a few years now, 4 or 5 years, this is something that might be seen. And that's also the reason why there was a search for newer agents to address osteoporosis, because we give them a rest after they've taken bisphosphonates for maybe 3 years or 5 years, because of the fear for this osteonecrosis and also the development of atypical fractures, which have been seen to happen with bisphosphonates use. So baliktad, imbes na ma-prevent yung fracture, mas nagkakaroon pa sila ng fracture because of its anti-resorptive effect. Hindi na dynamic yung bone. Now, just then to move on to the other non-hormonal treatments, the first is strontium ranelate. Ang tatandaan nyo lang sa strontium, it's the only one that is said to have a dual action. It is both anti-resorptive as well as anabolic. And the anti-resorptive effect is because it stimulates the calcium sensing receptors, and then this then leads to the osteoclast apoptosis. So it's this pathway that leads to the apoptosis of the osteoclast. And on the other hand, it stimulates the osteoblast to secrete osteoprotegerine, which inhibits the osteoclastogenesis, or the so-called osteoclastogenesis inhibiting factor, while on the other hand, reducing the activation of the rank ligand. So both siya, bone forming or anabolic as well as anti-resorptive. Yun nga lang, mahina kasi siyang drug. And that's why in terms of increasing the bone mineral density, so theoretically, it's a very good drug. But in terms of actual clinical practice, it's not, it doesn't really improve the BMD all that much. Okay, now we move on to other drugs, no? And again, please take note of these two drugs because they're relatively new. The first is a calcium mimetic called cinacalcet. It's specifically indicated for osteoporosis due to primary hyperparathyroidism. So in primary hyperparathyroidism, di ba, ang taas na ng PTH, it stimulates then calcium dynamics. So you become hypercalcemic. And then the increase in calcium level doesn't anymore shut down the PTH secretion. So you have a loss of the feedback. And so if you give this calcium mimetic, it actually activates the calcium sensing receptor and inhibits the parathyroid hormone secretion. So this is now used on an adjunctive basis for the treatment of hyperparathyroidism, especially primary hyperparathyroidism. Next, in terms of the non-hormonal therapies, we have denosumab. Denosumab is a monoclonal antibody which binds to the rank ligand and therefore prevents it from stimulating osteoclast differentiation and function, and therefore inhibiting bone resorption. So if you think about denosumab, it's probably second line already. So after the bisphosphonates, denosumab and also teriparatide are already considered to be second line for the treatment of osteoporosis. Okay, so the next drugs are the hormonal therapies. Teriparatide is a recombinant parathyroid hormone. It's the 134 fragment. So parang siguro your question is, why should you use parathyroid hormone when in fact it actually leads to bone resorption? That's true if you give parathyroid hormone at high doses, dire-derecho, continuously. Yes, it will induce bone resorption, hypercalcemia, and hyperphosphatemia. But if you give it intermittently at low doses, such as by giving teriparatide, then this produces a net increase in bone formation. So teriparatide is now considered to be, as I said, one of the drugs for the treatment of osteoporosis. So let's say, nabigyan mo na sila ng bisphosphonates. It's already 5 years. You have not yet achieved your target in terms of BMD. They still have a risk for fracture. Then you can choose. Is it denosumab or is it teriparatide that you would like to give? Okay, the next drug is calcitonin, which is probably familiar to you because it is a thyroid hormone produced by the parafollicular C cells in the thyroid gland. When you give it, it actually inhibits bone resorption, but it's not given for the long term because ultimately bone formation is also reduced by the administration of calcitonin. So para saan siya? Ba't pa siya binibigay? It's actually good to give in the treatment of painful osteoporosis. Let's say you have vertebral osteoporosis and you want to rapidly stop the resorption and decrease the pain. Calcitonin, which is available as a nasal, as an intranasal spray, is typically the drug of choice for pain from osteoporosis. Yun nga lang, hindi na rin siya ganun ka-available lately. Okay, so again, hormonal therapy, while you can give estrogen pa rin at low doses, there is fear of the venous thromboembolism, and that's why they thought that maybe it's better to give a SERM, or a selective estrogen receptor modulator. So it interacts with the estrogen receptors and you know that estrogen by itself inhibits bone resorption. But because it's selective, it doesn't stimulate the breast or the endometrial hyperplasia. So it's selective to bone resorption, and therefore can be used as an adjunct in menopausal osteoporosis. So although the risk for VTE is less, it's still there. And so you check out the risk, if patients have risk for this at baseline, so that you can then protect them or not use these drugs if they have risk factors. Okay, so that's the outline of the lecture for osteoporosis. Again, the most important part is that table. that talks about the anabolic and the anti-resorptive. The drug of choice is really the bisphosphonates. No? Take note of the new drugs. And the only drug so far which is considered to be a strong anabolic agent is teriparatide, or 134 parathyroid hormone. So we'll have a few questions just to check out if you understood this part of the lecture. Which of these medications is incorporated in bone and causes apoptosis of osteoclast when taken up during bone resorption? Is it A, alendronate, B, strontium, C, raloxifene, and D, teriparatide? Yung best answer kasi like some of them also have that action, but which of the drugs is best described by this question or by this phrase? Okay, so it's alendronate being a bisphosphonate. Tama rin naman yung mga sumagot ng strontium. Pero best answer kasi ang tanong eh. So ang best is this one, pero pwede rin nga yung strontium. Yun nga lang, hindi siya as the question is more specific for the bisphosphonates. Pero tama rin yung mga sumagot ng strontium. Okay, which of these drugs stimulates bone formation? Ayan, dapat 100% yan. Is it thyroid hormones, glucocorticoids, estrogen, constant, mali rin to. May mali sa tanong. Pero sige, sinasagot na rin nila. Yung mali kasi sa tanong is, it's not so much bone formation as inhibiting bone resorption. And the answer would be the hormonal therapy, such as estrogen. So tama yung the greater majority of you who answered it. Mali yung lahat because thyroid hormones, glucocorticoids, and constant high levels of PTH actually decrease bone formation. Okay. Calcium supplements that have the highest amount of elemental calcium at equivalent doses. Okay, so dapat wala nang magkamali dyan. Okay. Yung advantage lang nung, meron kasi internationally na calcium gluconate na oral. Pero sa Philippines, the calcium gluconate that's available is IV. Kaya baka may sumasagot ng calcium gluconate. Kasi yung naaalala nila is the IV calcium gluconate. We're talking about here the oral supplements. No? So in terms of the oral supplements, it's actually calcium carbonate. So naintindihan ko naman, but sinasagot ng iba yung calcium gluconate. Kasi, diba, the bioavailability is highest kasi IV calcium gluconate yung pinag-uusapan. But we're talking about here oral supplements. Okay, next. Which of these drugs is an anabolic agent which builds up bone in osteoporosis? And in fact,
sorry ma'am, last question na yan ma'am. Wala nang
last na. Okay, so maybe I can just show them the question. Which of these drugs is an anabolic agent which builds up bone in osteoporosis? Okay, so raloxifene is the SERM, diba? Bisphosphonate is an anti-resorptive. Daily teriparatide administration. So even if it's daily, it's low doses of PTH. And so the correct answer is C. Calcitonin has the unique ability to rapidly decrease bone resorption, but it's mostly actually used for painful osteoporosis. So the answer is C. Okay. Ayan, may sagot na kagad. Sorry, hindi ko na-erase. So the most feared adverse drug reaction of alendronate is osteonecrosis of the jaw. Esophageal cancer has also been known to happen, but ang nakalagay kasi most feared. Venous thrombophlebitis in the SERM as well as estrogen. Okay. Sige, so just read out the question and then think about which is the best answer, which is true regarding bisphosphonates. They're given indefinitely. Ibandronic acid. So hindi ko masyado kasing dinetail yung mga bisphosphonates, no? But ibandronic acid is unique because it can be given once a month. The problem with ibandronic acid is wala siyang effect masyado sa spine fracture. So wrong answer to. Yung A, wrong answer din yan because you can't give them indefinitely. because of the fear nga of the osteonecrosis of the jaw. Should be taken together. It doesn't need to be taken together with calcium supplements. You can take them separately. And then the correct answer is C. Okay. Ito rin, may sagot na, sorry. Drug for pain, yeah, which I said. Okay. And I think alam nyo din naman to. Okay, the last. Ayan, this one actually, hindi to galing sa PRC questions. This came from an international reference, no? But I thought to put it here kasi hindi to masyadong well-known. So a 55-year-old menopausal woman develops weakness, polyuria, and polydipsia. So non-specific yung complaint, but because there was polyuria and polydipsia, they thought baka nagdi-DI yung patient. And then for some reason, they did CT scan, and so what they saw was nephrocalcinosis. And the question is, which of the following may have caused this adverse effect of nephrocalcinosis? No? And who can guess at the answer? Ito PTH ata to, parathyroid hormone. Hindi lang na-complete yung question. The answer is actually vitamin D. This is an adverse drug reaction of hypervitaminosis that you can develop actually nephrocalcinosis. Okay. So I'm done with that part. Maybe just a 5-minute break. And my question, it's actually already 3:30, but I just have one more topic. Are you guys still up to it? Kaya nyo pa ba? Hanggang 4 lang.
We'll take, okay lang ma'am, just a short break na lang po.
So we'll probably resume at, it's 3:30 by my watch. We'll resume at 3:35 or 3:40 na lang.